Hi everyone, my name is Lindsay Carricker and this is my Diet 419 case study presentation on peptic ulcer disease. Peptic ulcer disease, or PUD, is a condition where ulcerations occur in the mucosal lining of the GI tract. They typically occur in the stomach, esophagus, or in this case the duodenum. So I'm just going to give you a brief overview of PUD. As I just mentioned, ulcers occur in different parts of the upper GI tract, and the continuous insult from acidic gastric secretions can erode the affected area, which can lead to bleeding and perforation. H. pylori and chronic NSAID use is the main culprit for developing PUD. And the genetic component of this disease comes from familial exposure to H. pylori. Some factors that exacerbate PUD, causing heartburn, epigastric pain, nausea, vomiting, and weight loss include smoking, alcohol consumption, and certain foods and beverages. I'll name some foods and beverages at the end of the presentation that might make PUD worse, but in general, large meal portions and eating and drinking certain things can end up relaxing the lower esophageal sphincter, or the LES, delay gastric emptying time, and increase gastric acid production. My patient is a 38-year-old Hispanic female with a history of GERD. She has a family history of diabetes and PUD. So she began experiencing symptoms including hematemesis, which is vomiting blood, and diarrhea. She recently lost 10 pounds prior to her admission to the emergency department, and she was admitted there for GI workup to address her symptoms. They did an endoscopy and found a 2-centimeter perforated duodenal ulcer, and they also took a biopsy, which was found to be positive for the H. pylori infection. Her surgical treatment included a gastrojejunostomy, which is when they connect a different portion of the intestine to the stomach. And post-op, she is currently NPO with ice chips and receiving enteral nutrition. So I'll tell you a little bit more about Maria's daily lifestyle. She is widowed. She lives with her 2 daughters, and she works a Monday through Friday 9-to-5 job as a computer programmer. When I met with Maria, she told me that she doesn't eat dinner until late at night because she's cooking dinner and tending to her children, usually helping them with homework. She does not drink alcohol, but she admitted that she does smoke. And when she was diagnosed with GERD about a year ago, she never received any nutrition therapy or consultation. So I couldn't collect a 24-hour diet recall because she is NPO, but I was able to get an idea of what her usual intake was prior to the surgical procedure. And as you can gather by looking at her intake here, her breakfasts on the weekends seem large, as well as her dinner portions, but what sticks out the most is her excessive caffeine intake. These are the medications that were prescribed to the patient after surgery. I found that taking this specific combination of drugs is used to treat the H. pylori infection. The food-drug interactions for the bismuth subsalicylate and the antibiotic, the metroiazole. The food-drug interaction for those is alcohol, which shouldn't be an issue according to the patient telling me that she doesn't drink. But here they have some significant interactions for the other 2 drugs that should be considered. Tetracycline can decrease absorption of iron, calcium, zinc, and magnesium, and omeprazole can decrease absorption of calcium, B12, vitamin C, and folic acid. She has to take the antibiotic tetracycline 4 times a day and the PPI 2 times a day. So it's best just to ensure that she's not eating meals or taking supplements with the 2 bottom medications. So these are her lab values at the emergency room. All the values can be altered from her decreased food intake prior to surgery, the H. pylori infection, the duodenal ulcer that caused bleeding, and the actual stress imposed on her body from surgery. There are many other causes to these abnormalities than the other ones I just talked about, but I will just be sure to keep an eye on these and see if they improve. So here are her anthropometric values. She's 5'2", 110 pounds, and her BMI is 20.1. And her current weight is 100% of her ideal body weight. I created 2 PES statements and 2 goals for Maria. The first is excessive caffeine intake related to food and nutrition related knowledge deficit, secondary to gastritis, GERD, and the perforated duodenal ulcer, as evidenced by usual dietary intake of 8 to 10 cups of coffee and 1 to 2 12-ounce soft drinks daily. The second is unintended weight loss related to hematemesis, vomiting, diarrhea, and reduced food intake prior to ED admission, secondary to perforated duodenal ulcer, as evidenced by NPO status and recent 10-pound weight loss. The goals we set include adopting dietary and lifestyle factors to minimize symptoms, decrease pain, and promote healing, and for her to gradually gain weight over time by resuming her by-mouth feeding and her new nutrition prescription. Here are my interventions for Maria. I suggested she make a food and symptom diary, which is basically a normal food diary, but if she experiences any flare-ups, she'll just have to write down the symptoms associated with that meal or the particular food or beverage, and then try to avoid that item. And once she gets back to her normal diet, it's important not to restrict foods except for a select few. Foods you should avoid with PUD are subjective, so when she brings back her food and symptom diary at her follow-up appointment, I can look at it and see how we can further help manage her symptoms. We also made another goal together to have her work on reducing her coffee consumption by her follow-up appointment. We also discussed her daughter's involvement with Maria in the kitchen and that she eats dinner really late because of her busy schedule. So we made a goal together that she could attempt to meal prep on the weekends with her children's help. And when she comes home from work on the weekdays, she can just heat up her prepared meal for her and her family and try to be finished with dinner at least 2 hours before laying down for bed at night. She also stated that she'd break up her meals into smaller portions throughout the day, which I can check that at her follow-up appointment with her food and symptom diary. Her nutrition prescription will temporarily be a bland diet. I collected some research about this being helpful post-op, especially for GI surgeries to encourage healing. Then after that, she can eat foods according to what her symptoms are telling her. She will be eating by mouth when her doctor gives her clearance and she is weaned off of the enteral nutrition. These are the things I will monitor and evaluate at her next meeting with me. I discussed all of these already for the most part, so I won't go over them again, but they're listed here. And these are the foods that I said I'd kind of mention at the end of my presentation. These are the foods that should be avoided with PUD, so here they are. So we have alcohol, coffee, chocolate, tea, and pepper. This should be avoided because they increase gastric secretion along with other things that make PUD worse. Another thing that's usually avoided are high-fat foods, but again, that's all according to how the patient's body reacts to food. And foods with added salt and sugar should also be limited.